Bye. Hey everybody, welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken. Welcome to your nonstop shop. Your one-stop shop. Nonstop. This is not a nonstop shop. I do close down occasionally. I am an ophthalmologist after all. I have very specific hours that I like to work. This is your one-stop shop for all things eyeballs, eyeball-related things. And I do have some interesting eyeball stuff. I think something that I haven't talked about yet. I'll present it as kind of a mystery case, but not really. The mystery will be revealed very quickly, but I'll take you into the exam room with me and how I approach a problem in ophthalmology, that a type of patient that comes up periodically, not very often, but it can be very challenging to figure out. So anyway, we'll get to that after the first break. First, just a couple things. I'm going to try to concentrate on this episode. It's going to be hard given that Taylor Swift just announced her engagement to Travis Kelsey. The news just dropped. And honestly, I'm not a Swiftie. My kids love Taylor Swift. But and by association, I also have to love Taylor Swift. I don't have a problem with her. But I am a huge fan of Travis Kelsey. I love I love his podcast, but also I'm a big Kansas City Chiefs fan. So, obviously it's a big deal. And people are gonna in the comments maybe be like, "Oh, are you from Kansas City?" No, I'm not. I'm not like a lifer Chiefs fan. I joined the bandwagon when Patrick Mahomes was drafted, because Patrick Mahomes went to Texas Tech University. I graduated from Texas Tech University. So ask any Red Raider, any former Red Raider, current Red Raider, like Patrick Mahomes, he walks on water. He's like royalty to us. We will follow him to the ends of the earth and do any as I gotta assume the most famous person to ever graduate from Texas Tech University. Like it's got to be him. I can't think of honestly anybody else. And so anyway, so I adopted the Chiefs as my NFL team of choice. I do love watching football, and also I might as well tell you I'm turning 40 coming up. October 2nd is my birthday, and my family got me tickets in Kansas City to see the Chiefs play the Ravens on September 28th. I'm so excited. I've never been to a Chiefs game. I've been to a handful of NFL games over the years, but never a Chiefs game. So I'm so pumped. I'm excited. And I'm going to do tailgating. I'm going to do the whole thing. I'm going to do the whole Chiefs fan experience. So anyway, happy early birthday to me, I guess. I don't usually do you guys do like when I feel like 40 is like the last time that you like really have a good excuse to have like a big party. Maybe we should always have big parties for our birthday, but I don't know, like through my 30s, I really haven't had any like big parties, like any big thing. It hasn't seemed important enough. I don't know. I should maybe have a rebirth day on the day of my cardiac arrest, but that's a whole different vibe. So anyway, celebrating my 40th. Maybe I'll celebrate my 50th down the road if I get there. Not to be morbid. But 40, it's coming. And soon after it, presbyopia. We talked about that on the last episode. You guys remember that? And so I have that to look forward to, but I'm trying to keep it positive. Going to see a Chiefs game. I'm so excited. All right. So a couple other things before we get to ophthalmology stuff. An interesting topic came up. There was a news article. I can't remember where I saw this, but it was people in med school academic circles talking about, should med school be 3 years? And the reason that it periodically becomes like a big topic of conversation. I don't know if it's ever going to go anywhere, but it is an interesting debate, interesting thing to discuss. Should we be able to graduate med students in 3 years? Well, first of all, is it possible? I would say yes. You can condense the curriculum into 3 years. That is possible. And over the years, I've made jokes like, yeah, what, like the 4th year, it's kind of like We're not really, doing much. We're interviewing. It's a very lazy, easy year after 3 brutally difficult years. And so could you just get rid of it and just like push everything together? Yeah, I think you could physically do that. I saw some arguments that actually the pretty good arguments, I would say, is like, would that in effect cheapen the reputation that doctors have? Whenever you shorten training, uh, that it might not be a good look. You might still get the same education, but the fact that you're shortening it, you're decreasing the amount of time. It would decrease probably the amount of like clinical hours that you have. Does that kind of shortchange future physicians in terms of their expertise, in terms of their uh, the power that they have and looking for jobs and getting paid what they need to pay to repay their loans? And so does that affect the earning potential, I guess is what I'm saying. And so that's an interesting thought. But also I I didn't know I wanted to do ophthalmology until like the beginning of my 4th year, like right at the beginning. It took me a long time to figure out what I wanted to do. So I needed all 4 of those years. I needed all that time to decide where I wanted to go in my life. And I don't know how that's going to work for people that come into med school completely undifferentiated. They have no idea what they want to be. Not everybody knows they're going to be, a a left kidney doctor, right away. So I'm just kidding. That doesn't exist. I don't think. Maybe it does. I don't know. Can you focus on one kidney versus the other? Probably not. They're very similar. And so I don't know. Here's where I've come down on this after thinking about it for a few days now. I like what Europe does, what lots of other countries do, where you just basically combine like undergraduate education and med school. Like, why don't we have more 6-year programs? Like that makes sense, right? Like you do, 2 years of college and then you immediately go into medical school. That does exist in like a couple spots in this country, like the very special programs, but I think it's just generally just widespread in a lot of different places. That's just how they do it. And because a lot of pre-meds, they know about halfway through college, like that's kind of the way they want to go about it, maybe even earlier. And so I think I'd prefer that. Do like a 6-year combined. You get your bachelor's degree and your MD in a 6-year period versus currently 8 years, or just shortening med school into 3 years. I don't know. That's kind of my thought. The 4th year, it is easy in med school, but it's also sometimes very valuable. Like it was valuable for me. And also, I mean, you're interviewing, it's just like it's like a victory lap for a lot of people. It feels good to have that victory lap. It's like the last one you're gonna get forever. After that 4th year of med school, yeah, that's it. Like it's busy, and it gets busier, and life just gets more complicated and difficult. So, and more rewarding though, because you're practicing medicine, you're doing your thing. Um, all right. So anyway, that's my med school 3 years thoughts. One last thing. Just recently, I gave a talk to the Oregon Health and Sciences University. I live here in Portland. So I went to talk to the OHSU med students. Wasn't all the med students. It was on a Saturday. Yes, I did come in to work on a Saturday. I made sure I pointed that out to them. Like, this is special. You guys are special. I'm an ophthalmologist. I'm working on a Saturday. All right. Don't tell the other ophthalmologists. So I went in and give a talk. It was sponsored by Oregon, the OHSU, what is it? The Students for a National Health Program, SNAP. This is what they called it, SNAP. I think it's all over the country, but and so a lot of the students there were motivated politically. They were into advocacy. They just had that enthusiasm that you have right at the beginning of your career. The healthcare system hasn't beaten them down. They're bright-eyed, they have they're opinionated, they have a sense of that compassion and that just need to make the world a better place for themselves, for their patients. It just, you could feel it in the room. And it just struck me like how much of that physicians lose over time. I think a lot of that's just life, you know, sometimes experience, and you get jaded. You do. The our healthcare system is tries to beat doctors down. You know, we work harder and harder every year for less and less pay. And it you get the feeling like, and we're fighting misinformation. We have a government wanting to take away research funding and funding for Medicaid, and it just all these it just we're getting hit in all different directions. Patients too, but also physicians. And so that's why you don't let anybody like try to convince you that we are in charge of anything in healthcare. I think we should be in charge. We need more ownership in healthcare, but we don't have it. And I think that's a disconnect that a lot of people have, the public has. And it's fueled by a lot of stuff that RFK Jr. talks about, making it seem like we have control and we're dictating how much we get paid and that we're doing all this for money. And it's, yeah, we get paid for what we do, but that's not the driving force. Anyway, I've talked about all this stuff ad nauseum. So anyway, it was so much fun to talk to this group of students. It was like probably 150 of them showed up. It was awesome. We did a little Q&A. I gave them a little background on me, talked about social media. And one thing, and the reason I'm bringing this up before we take a quick break, is that one of the questions I get asked, uh, especially if there's a lot of med students and residents in the room, is how do we how do we fix it? Like, what would you do? What do you think is the best way to go about this? And so, first thing I did was I told all of them, I love that you're all interested. You all want universal healthcare. I want universal healthcare. Of course I do. I want healthcare that's accessible and affordable to every person in this country. I don't know anybody that would disagree with that. Why is that not a wonderful goal for us to achieve as a society? Accessible, affordable healthcare for everyone. Where a lot of people differ is how to go about that. See, I don't think we're ever going to pass one piece of legislation that's going to get us that. That's why, like, I don't do a lot of content where I'm like saying, I'm like beating the drum. Let's get universal health care. Of course I want that. But that type of message, I think it can feel a little bit empty. A little bit like, oh, universal health care, another person wanting universal health care. Because it feels so far away. Like we can't, like, how are we ever going to get that? We're not going to pass. Our country is too divided. We are never going to pass one thing. And maybe this is just me being pessimistic. All right. Disagree with me if you want. But I don't think we're ever going to pass one thing that's going to be like, this is the legislation that will get us accessible, affordable healthcare for everyone. I just don't think that's going to happen. All right. And so my approach, and this is what I told the students, I was like, we can't just lose sight of the small gains that we can get, that we can obtain over time to make life better in pursuit of this ideal situation of universal healthcare, right? Like stepwise, what can we do? What can we realistically accomplish to make the healthcare system better? Can we reform prior authorization? Can we scale back PBMs? Can we enforce price transparency? Can we decrease the corporatization of medicine? Can we put some transparency on health insurance companies? All right, around the peer-to-peer review stuff. You know, all these little tiny things that we can do that we can really make a difference in order to work toward that goal of everybody having affordable, accessible healthcare. Also, that allows physicians to do what we want to do, which is practice medicine to the fullest extent that we can. All right, without meddling from insurance companies. So that was my message to them, as like, yeah, you want universal healthcare, but like, let's really focus on some things that we can like do today versus hoping for some grand sweeping piece of legislation that'll change everything. So I don't know if that's going to happen. All right, let's take a break. Hey, Kristen.
Yeah.
I know that you love when I talk about the cute little mites.
Mm-hmm.
Yeah, but I thought we could take a break from that. Is that okay with you?
That's fine.
Yeah, because I'd like to focus on the eyelid symptoms and disease that an overgrowth of Demodex causes.
Okay, I like that idea. No mite talk.
So Demodex blepharitis, it often gets misdiagnosed or just missed entirely because a lot of symptoms overlap with other eye conditions.
Okay, so what are the top symptoms that people should look out for?
Usually itching along the eyelid margin, swelling, irritation, redness.
That sounds like it could be allergies or lots of other things, too.
It could be a lot of things, but exactly. And the key is if your doctor spots crusties on the margin of the eyelid.
Mm-hmm. Technical term.
Well, we call them collarettes, but crusties is a good term. That tells you it's Demodex blepharitis right there.
Well, I really like that there's a clear sign to know for sure.
And once you're diagnosed, there's a prescription eye drop treatment available for this disease.
Oh, that is good to know.
To learn about the common symptoms of Demodex blepharitis and more, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. I wish I knew, though, how to, going back to this talk I gave to the med students, I wish I knew how to, like, how they can keep their excitement, their enthusiasm for this stuff, for advocacy. And that's one of the questions they asked me. And I kind of fumbled around. I was like, oh, man, I don't know. What I told them, what I settled on was like, write down everything you're feeling now. Write down your motivation for being in this room right now, other than like they want to meet the TikTok guy. Like, why are you part of this Students for a National Health program? What is driving you to be here, to think about these things, think about improving healthcare system? Write that down. Because that's something that might go away as you get further in your career and other things take precedent. You get married, you have a family, I don't know, you got health issues. Take it from me, like that kind of stuff happens, but keep that somewhere that you can refer to. You can look back and be like, oh, that's what I really cared about. Back when my life was a little bit less complicated. I had more time. I was just trying to learn how to be a doctor. Those are the things I cared about. I think it's helpful. So I'll be able to refer back to that, but it's hard. I don't know other things you can do to like maintain your compassion and your desire to just make the world a better place through the practice of medicine. It's hard. It's hard for people. People are leaving medicine for that reason, because they lose that, so it's a tough question to answer. All right, let's do some ophthalmology, shall we? You guys have been waiting around 20 long minutes for me to finally talk about eyeballs. I did give them some tips. Those med students, I gave them some tips on how to use a slit lamp because they had just had their like ophthalmology lectures, and they had more than one, which is better than what I had. That's great. They had like several lectures, and they all dilated each other's eyeballs. So I was very excited. I showed up right at the right time. All their eyeball knowledge was fresh. We talked about checking vision and using a slit lamp, and how most of them will never even see another slit lamp for the rest of their lives, and how that made me sad. And I shouted out the students that were going into ophthalmology. They were my favorites. The rest of them, fine. They're okay. They seem reasonably smart. But those med students going to ophthalmology, I love them. They're great. Shout out ophthalmology as a career choice, by the way. I mean, you know, would you expect anything less from me on this podcast called Knock Knock Eye? Okay, so here's our patient. We're in clinic. We're trudging along. We got like 40 patients. It's a long day. And a new patient comes in. We'll say about 20-year-old gentleman, young adult, comes in. He has a report of vision loss. That's all I'm given. And so I go in, I look at the chart, and the technician has measured no light perception in one eye. So the details of this are kind of made up, but this exact situation has happened to me in clinic before, as far as one eye having no light perception. That's what was measured. That's what the patient is reporting. The other eye's fine, 20/20, but no light perception vision. All right. So what am I right away thinking? Okay, interesting. Like, it's very rare to have no light perception, particularly in a young person. So I can count on one hand. In fact, I'll do it. One hand, the things that can cause no light perception vision, where you cover one eye, you shine the brightest light in the world right in front of that eye, that affected eye, and the patient will not see a photon of light. Very few things give you that. All right, here we go. Giant cell arteritis. That's one. Very serious. All of these are very serious diagnoses. You have open globe injuries, bad trauma. Usually the retina's completely detached. The eye's full of blood, might not see any light. Angle closure glaucoma. If the eye pressure is high enough, it's going to decrease all blood flow to the optic nerve, and you'll get that. So very serious problem. Retrobulbar hemorrhage causing causing increased pressure. So kind of similar to angle closure glaucoma, but a different mechanism. So you have a retrobulbar hemorrhage, blood pushing the eye forward, increases the pressure. Again, big traumatic situation. All right, so that's 4. What am I missing? Honestly, endophthalmitis is another one. So a bad enough infection that that the patient has lost all vision. All right. So you can also, there are certain other things that might cause it, chemical injuries. You could get a little bit, even with those, often you'll have some light perception at least. So it's very hard to just totally take out the entire optic nerve, the entire nerve fiber layer. None of the photoreceptors are functioning. Like, it's really hard to have that. And so I'm seeing this on the chart, and this patient clearly has not had any trauma. We've asked the patient, no trauma. All right. Not in an age range that would have giant cell arteritis. Not going to happen in a 20-year-old. Not going to happen. Eye pressure is normal, so I know it's not angle closure glaucoma, and the patient's not in a lot of pain. Right, so that's going to take out all and without the trauma. So basically, there's nothing that I am aware of that I can think off the top of my head as a reason why a patient will have no light perception. Even something that would have like a relatively normal eye exam, like optic neuritis. Say someone with optic neuritis, maybe they have multiple sclerosis, which is a big association with optic neuritis. Even those patients, it's very extraordinarily rare to have like no light perception with optic neuritis. Usually you're going to have like hand motion vision, or at least light perception vision. And so that's going to be unlikely as well. So I'm thinking about all these possibilities within a few seconds of seeing the data, seeing the patient's vision, normal, totally unaffected eye on one side, no light perception vision on the other, normal eye pressure. I take a look at the eye. It's the first thing I do is I do my exam, look at the front of the eye, look at the back of the eye. Optic nerve looks okay. Retina looks fine. So at this point, with no light perception being the report, I have to entertain the possibility that this is non-physiologic visual loss, what we call sometimes functional vision loss, where there is no physiologic reason why someone would have this level of vision, meaning that the eye has the ability to see much better than the patient is reporting and that we're seeing on exam, on the subjective parts of the exam. And notice, I am not going to say that this patient, I will never say to a patient that they are faking it, that this isn't real, because that's different. That's different. So so if we're talking functional vision loss, there is kind of more malicious intent. And then also there's something that's more on the psychological spectrum. All right. A patient might honestly be experiencing this level of vision loss, even if it's not physiologic, it's non-physiologic. So there is like a very, very small subset of patient that might be trying to, you know, you know, commit insurance fraud. Maybe they were in an accident and they're pretending that they have a decrease in vision. I would say, in fact, I don't think I've ever actually seen a patient that falls into that bucket. Someone who's like has secondary gain from pretending to have this vision loss. But even in that situation, I still wouldn't say to the patient, I think you're faking it. All right. It's not appropriate. That's not ethical to do that. So what is my role then as the ophthalmologist? Well, my role is to use the physical exam and other techniques to try to show the patient that they do have vision in that eye, to be able to document accurately in the chart that the patient has non-physiologic vision loss, and to try to reassure the patient that their vision will be fine, that they will get better from this. Okay? So how do I do that? So the first thing, especially in someone with, in this case, no light perception vision, this is very easy to tell whether or not it's real. And that's with a pupil exam. All right. In a no light perception eye, the pupil will not constrict. That pupil will not constrict because that eye is technically, it's not seeing any light. And so it won't respond to light. So for that situation, all you got to do is put the light in front of the patient's eye. If the pupil constricts, you know that it's not known light perception. There is at least light perception to this eye. Okay, so that's actually pretty straightforward to dispel. It gets a little bit trickier with different levels of reported vision loss. So let's say the patient is reporting hand motion vision. All right, so that means that when you test them, they're able to see your hand moving in front of their face, but they're not able to read anything on the chart, even the big letters, 2400, 2200, they're not reading any of that. So what can you do to try to determine if this is actual, that level of vision loss? So I've done all the rest of the exam, everything looks fine, and so I'm suspecting non-physiologic vision loss. What can I do? So one thing we do is what's called an OKN drum test. So we will put a rotating drum that has black and white stripes in front of that eye, and we'll rotate that drum. And in someone who has at least 2400 vision, they'll have nystagmus in response to that. All right. So their eyes will kind of flick back and forth. If I see that on a patient's exam, I know they have at least 2400 vision, which is better than hand motion. All right. So I can estimate a little bit of what might be going on there. Right. Okay, so that's the OKN drum is one thing. Another thing we can do is what's called a mirror test. So what we do is we cover the better seeing eye, and we ask the patient to hold their eyes still, and then we'll slowly tilt a mirror from side to side in front of the eyes, holding it at a certain range. And if the patient's eyes move, then the patient can see that image. that's better than hand motion. All right. So you can think of a lot of these tests. Yeah, they're tricks. They are tricks. But we're not trying. We're not trying to like fool the patient to like humiliate them. That's not the idea here. All right. The idea is to get an accurate assessment of what this patient's vision is using objective techniques, something that doesn't require the patient's participation. You see the difference? Checking vision, asking someone to read the chart, that's subjective, right? They could say or not say whatever they see on the chart, right? It's subjective. Objective, these are objective measures, right? So it just gives us an objective way of assessing vision. There's also different things you can do with prisms. So you can hold prism in front of the eye, and if you see the eyes shift from one side to the other or alternate fixation, then you know they have a certain level of vision. The hardest thing, though, is when you have a patient who is reporting bilateral vision loss, or but mostly it's vision loss that's kind of minimally decreased. Let's say like they see 20/80 on the chart. And I, for the life of me, cannot figure out a reason for why that patient sees 20/80. That's my job as the ophthalmologist. When I see someone's visual acuity, whether it's 20/20, 20/40, 20/80, hand motion vision, I have to explain that vision. Why does that patient see that level and not any better? Do they have macular degeneration? Do they have glaucoma? Do they have cataract? Do they have any of the hundreds of other diagnoses that could cause you to have decreased vision? I have to explain that. When I can't explain it, then I have to start employing some of these techniques to try to explain it. So let's take one more break. I'll come back. And so for the patient that has like mildly decreased vision, like 20/80 level, what can I do to try to figure out exactly what the visual acuity might be? Okay, so we have a patient that is reporting 20/80 vision in both eyes in this situation. All right. But my exam tells me that this patient should be seeing perfect 20/20. I have no reason to think this patient would see 20/80. So what can I do to try to quote unquote trick the patient? What can I do to try to get more of an objective measurement? So here's one thing that's actually quite effective is what's called a bottom-up refraction. So normally when you're at the eye doctor, they'll start with the big letters and they'll slowly go down. And so this person would be like able to read 2200, 2100, they read 20/80, and then the next line, nope, can't see it. And nothing you do, refraction, putting lenses in front of them, nothing you do will let them see better than 20/80. So what we can do is what's called a bottom-up refraction. We start really low, really small, like smaller than any human could. And I don't even know why they even have this. Like they have 20. I think I've seen one chart that was like 28 or 2010. Every chart has a 2010. Very few human beings can see 2010. You're talking like the best baseball players in the world, like Ted Williams probably could have read the 2010 line. So it takes it's remarkable vision to be able to see 2010. So sometimes in this type of patient, we'll start low at that level. We'll say, okay, can you read this? And they'll be like, no, I can't read it. Oh, okay. Yeah, that's pretty small. And I'll go up to like 2015. I'll be like, okay, I'm pretty sure like you'll probably be able to see this a little bit better. Just give some encouragement. Like, okay, now we're getting kind of quite a bit bigger here. Well, compared to 2010, 2015 looks huge. And then to 2020. And so, and all along the way, as I'm getting bigger, I'm encouraging the patient. I'm really pushing them. I'm like, okay, I know this is small, but I'm pretty sure you can get this. You could probably see this letter, at least one of these letters. I'm really hammering it, trying to push them as hard as I can. And often what you'll see is you'll get to like 20/40 and patients will read a letter. And I feel much better about a patient's vision if I can get them to read at least to the 20/40 level. And so that's called the bottom up refraction. And so just compared to where they started, 2010, 2040 seems enormous. And so maybe, they'll read a letter that's, obviously quite a bit better than 20/80. So that's how we can kind of tease out what might be the actual visual acuity. So what do I do with this information? I mentioned earlier, I never tell someone, okay, you know what? You don't actually see 20/80, or you're not actually hand motion vision. Your eye is perfectly, you're healthy. You see perfect vision. I don't do that kind of stuff. All right. And you shouldn't, because that kind of talk is assuming ill intent. You're making the patient out to be the bad guy there, when this might be a psychological defense mechanism that this person, similar to like a conversion disorder that you'd have with other neurologic symptoms that you can't explain physiologically, or what are called non-epileptic seizures, formerly known as pseudo seizures. These things are physiologic manifestations of of sometimes psychological stress or trauma, right? So the patient, in their mind, they are blind. It's a psychological issue. And so sometimes for these patients, you refer them to a psychiatrist, and that can be a delicate conversation to have. But often what I've found, especially with young people, when this happens, and again, this doesn't happen very often, but what you'll do is just you reassure them. Be like, you know what? I understand your vision is not where we'd like it to be, but it's going to get better. This will improve. And then you just follow them more closely, right? So you don't just say, no, you see fine, go away, come back in a year. That's not the way to handle this. All right. You encourage them, you reassure them that, oh, this will get better. All right. Your vision, you're not going blind. You'll be okay. And then you see them more frequently, maybe a couple weeks. Come back. Let's take a look. It should be better by then. And often it is. Often they will read a little bit better on the chart. But if it's something that it seems like there's something very serious going on psychologically with the patient, then you get other people involved. But that's the way to approach non-physiologic vision loss. You don't accuse the patient. That's not going to get you anywhere. What's the point of doing that? All right. It's just going to create a hostile environment with the patient. They're not going to come back. They're going to go to another doctor, and then there'll be another doctor after that. And so why not just try to foster a trusting relationship with them and give that encouragement. All right. It really does help. But it's a fascinating, it's a very difficult thing that you have to deal with in the clinic, because you got a very busy clinic, and this goes to people that get really upset about the wait time in the clinic. Well, sometimes that's because of situations like this that we find ourselves in, where a patient with non-physiologic vision loss, they might need 45 minutes of your time. And that's something you can't plan for, right? And so it's it's a challenging situation, but we do our best. And communication's key there, by the way, guys. Like, tell the people in the waiting room, hey, we understand it's a wait. We apologize for that. We're doing the best we can. We'll be with you shortly. That kind of stuff really helps. It'll at least keep people from getting on Google and giving you a bad review. So anyway, all right, guys, that's it. That's Knock Knock Eye. That is all about non-physiologic vision loss. Sorry I didn't get to any comments today. I got I kept a few of them here. Maybe we'll address some of them later. I talked about in the most recent episode. I went a little bit all in on RFK Jr. Made a couple people not so happy. Most of you agree with me. The RFK Jr. is not great for doctors, not great for patients. So anyway, check out that episode. I appreciate all the comments. And thank you for listening. I am your host, Dr. Glockenflecken. Thanks to my producers, Aaron Corney, Rob Billman, and Shanti Brigg. Editor and engineer Jason Pertiza. Our music is by Omer Ben-Zvi. Knock Knock High is a human content production. We'll see you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.